You are welcome to my channel. Thanks for visiting. Today I'll be rounding up on respiratory failure, and that will lead me to the treatment of respiratory failure generally. Without wasting any of your time, let's go straight to the business. Now, when it is about treatment and we are faced with respiratory failure, it is going to be case by case, meaning no two cases will be completely the same. Let me explain further. Type 1 respiratory failure is obviously different from type 2 respiratory failure. Even two people with type 1 respiratory failure might be treated in similar but slightly different ways, because by the time we get down to the root cause of the problem, definitive intervention might be different. But regardless, all of us should be familiar with some basic steps or interventions in all respiratory failure types generally. We should prepare our mind to send consults to pulmonologists, respiratory therapists, cardiologists, nephrologists, surgeon, neurologists, as the case might be, and so on. First thing first is the airway patent. That is the first thing to be concerned about. Any foreign body there, any secretion, we must function appropriately. Then we will be ready to deliver oxygen. I will go more in depth on the delivery of oxygen in a bit, but let's have that at the back of our mind from the onset. As part of the basic interventions, oxygen will be delivered. Here, we are talking of respiratory failure. But remember, in COPD, we cannot deliver supplemental oxygen indefinitely. It must be regulated. We'll get into that in a bit. IV fluid. The type of IV fluid to be given. Why that? But we should be careful. We don't run into pulmonary edema as well. So that is part of what must be done early. Positioning of the patient is a big factor in helping when it comes to respiratory failure. Why that? Functional residual capacity will be high when the patient is erect or upright. It will be pretty low when the patient is lying supine. So, having that at the back of our mind, we have to be positioning the patient every 1 to 2 hours, right? Particularly in type 3 respiratory failure, post-operative condition, atelectasis, right? We don't want that to occur. So we keep our functional residual capacity to be high. So the patient can sit up at 45-degree angle of 45 degree, or lie prone positioning, not supine, please. Now, oxygen delivery route. If I have a stable patient, not in need of high oxygen, I don't need to deliver a very high volume of oxygen, I will go for nasal cannula using nasal prongs. That will deliver 100% oxygen, but low concentration and low flow. I cannot deliver more than 0.5 liters per minute to higher than 6 liters per minute. So I can only deliver between 0.5 liter to 6 liters per minute through this route. But if the patient before me is having type 2 respiratory failure, a non-COPD patient, and I need to control the oxygen delivery between 24 to 50%, I'll go for venturi mask. that will deliver low to moderate oxygen at 100% through a jet mixing device. If the situation requires a very high flow of oxygen, very high concentration, then I will go for reservoir face mask. That will contain 100% oxygen in the reservoir bag, and that will help, throughout the respiratory cycle. Okay. In addition, if I need to deliver up to 15 liters per minute, I will go for resuscitation bag mask valve unit. Very high oxygen could be delivered, very high flow rate. Yeah, that will help. But if I cannot or I don't want to embark on endotracheal intubation and the patient is moribund, I can go for non-invasive positive pressure ventilation. That will provide ventilatory assistance and is going to be controlled. That is the alternative I have to endotracheal intubation. Now, if I'm not going for all these things and I can have endotracheal intubation, I can have endotracheal intubation with mechanical ventilation down. So I've just mentioned endotracheal intubation. If that is not successful, we can't waste any time. We have to save time. We have to act fast. Tracheostomy can be done. Corticosteroids will help in so many conditions. And of course, with bronchodilators, in COPD, in asthma. Incentives spirometry, respiratory therapy, physiotherapy can all be embarked upon by respiratory therapists or as instructed by pulmonologists. Okay? This will help tremendously, particularly in type 3 respiratory failure that is having atelectasis postoperatively. Then CPAP can even be started at home in individuals that will be dealing with respiratory failure, off and on, intermittently. CPAP will be very helpful. Now, specific intervention. All I have gone through before now is what is expected in most cases. But when we have taken history, and history is leading us to more investigations like chest X-ray, CT, cardiac workup, renal, even neuro, and so on, including orthopedics. Then we'll be able to come to the primary problem. So definitive diagnosis will be made. When that is the case, then the primary problem must be solved in the manner that it will warrant. So primary problem is identified after thorough history, physical examination, and more investigations, and that will be treated. Let me give you an example. This is respiratory failure, but the cause is autoimmune condition. If we do not address the autoimmune condition, the patient will feel better for a while after the initial interventions, but he or she will come back with the same problem. So we'll get to the root and get it uprooted. Now, typical examples of specific interventions will be: 1, the use of antibiotics. If pneumonia or septic shock under type 4, distributive shock under type 4 is responsible for this respiratory failure, then we'll go for antibiotics right away. It might be antifungal, it might be antiviral agent, depending on the causative agent leading to the sepsis and septic shock. Now also, narcotics is responsible. We don't need to waste our time. We'll go for that. EpiPen, Benadryl, steroids. You know what I'm talking about, right? Anaphylactic shock, right? Anaphylaxis, allergies, right? IV fluid or blood transfusion. You know what the diagnosis is likely going to be, right? When we are dealing with hypovolemic shock, we might need blood transfusion in many conditions, including IV fluid, but we should be careful, no overloading, because while trying to help, we can add salt to injury by treating the patient to pulmonary edema. It can even be cerebral edema. So in that case, we look for high cylinder diuretics like laces to send the fluid out. Bicarbonate. This is controversial in the sense that majority will run away from the use of bicarb generally, sodium bicarbonate, either 4.2 or 8.4%. So run away from it. Why that? It is even taken out of the algorithm for advanced cardiac life support a long time ago because the benefits is less compared to the adverse outcome when you use bicarbonate. But some people will ask, why have you put it here then? Some authorities have given the opportunity to the window that if the pH is less than 7.10, some will say if it's less than 7.15, then look for bicarb, particularly when the natural buffer in the system is not helping to achieve compensation with the respiratory acidosis. So the use of bicarb, discuss with other physicians around before using it. Left to me, I won't. Disease-modifying anti-rheumatic drugs or steroids in autoimmune conditions, right? Vasopressors when the BP is continuously down. Vasopressors here can be anything like epinephrine in asthma or anaphylaxis, norepinephrine mostly in type 4 respiratory failure with shock, but it's better to use this if we are faced with septic shock. Dobutamine in cardiogenic shock will be very helpful, and dopamine can be helpful. Vasopressin is useful in hypertension as well, so vasopressors are good. Diuretics, I've mentioned this repeatedly, and why do I need to mention it again? When we have discovered that there is fluid overload, not all diuretics will be helpful here. In pulmonary edema, let's go for high saline diuretics. Methacrenic acid, metanine, and furosemide. But I will settle down for furosemide, lases. Intravenous immunoglobulin, I would not delve too much here because this is pretty expensive, except as being prescribed by a specialist. Intravenous immunoglobulin is pretty expensive. When the diagnosis is pointing to the use of it, after due consultation with the expert, then you can embark on it. Now, surgery might be the cure of this respiratory failure. Why that? If it is as a result of cardiovascular anomaly, particularly cardiac tamponade, we don't need any grammar. In cardiac tamponade, we just have to release the tension quickly. In tension pneumothorax, we don't need medical jargon. What we need is sticking the needle, let the air go. Ascites, there's no need of story. We just have to drain. Aortic stenosis that is this bad, then cardiothoracic surgeon is going to be needed. In flare chest with massive pain, rib fracture, please give generous analgesia. But for the patient to go back home and thank you in future, call orthopedics, please. Spinal cord injury, you know where to go. Septal defect, we call back cardiologist or cardiothoracic surgeon. Lung transplantation, yeah, this is the big one. It's going to take time. And some people might be fortunate that one way or the other, something will happen somewhere and that will be available. Well, we'll pay for those who will need it as well as those who would have lost their loved ones and who will allow such organ to be taken. The same with heart transplantation. These two will offer permanent solution to some deep troubles of respiratory failure, but not easy to come by. With that, I've come to the end of this short presentation on how to go about respiratory failure. We cannot exhaust everything, but this little will help. Thanks for listening. Please remember to subscribe to my channel and oh yeah, let me quickly drop this. I remember permissive hypercapnia. No, in that case, you allow for retention of CO2, but that must be with the order of a pulmonologist. Thanks for listening. Please remember to subscribe. I appreciate it.